Hi there, Dr. Nicola here. Welcome to New Frontiers in Lyme Treatment, updates on emerging and adjunctive medications. So just a quick disclaimer on this lesson. This presentation is for informational and educational purposes only and does not constitute medical advice. The content presented is not intended to diagnose, treat, cure, or prevent any disease. And always consult with your qualified healthcare provider before making any changes to your medical care or treatment plan. So the reason I wanted to do this update is to just kind of give some information on some therapies, medications, treatments that we've been using more in the last, 2 to 3 years. Some things that hold promise for the future, some things that I see working well. And it is important because, we've had standard antibiotic protocols and herbal protocols and things in place, but there's a lot of people who do have persistent Lyme symptoms in spite of that. So we always need to be looking for what else? What else can we introduce? What else can we try? What else has promise? It's important because there's biofilm formation, persister cells, as we're learning more about, co-infections to deal with. There's always something. And then chronic immune dysregulation and toxic load. I'm seeing a ton more mold, or maybe I'm just recognizing a lot more mold in our Lyme folks. And so that really needs its whole other level of prioritization. Also seeing a lot of MCAS, mast cell activation syndrome, some autoimmune. So we've got a bunch of different things going on that can be triggered by the chronic pathogens, the tick-borne infections. So we really need advanced, integrative, and personalized strategies. So this is part one. This is going to be an overview of emerging antibiotics, or antimicrobials, I should say, strictly. So we're going to talk about ivermectin, piperacillin, tafenaquine, methylene blue, and dapsone. And then in part two, we'll cover other notable treatments that aren't strictly antibiotics or antimicrobials, but that do have a place in Lyme treatment. So we're going to look at low-dose naltrexone, which I realize is not new, but I just wanted to talk about it because I do see it being helpful in a lot of my patients. GLP-1 agonists, such as semaglutide and tirzepatide, which I'm using more not only for metabolic support, but also for neuroinflammation and modulation. So we'll talk about that. And then SOT therapy, which is now called Q-Restrain. It's been renamed, so we've all got to train ourselves to call it Q-Restrain instead of SOT, which is a gene silencing therapy. And that's very cool as well. So we'll talk about that in part two. We have a lot of information to get through. I wanted to make this comprehensive. So let's jump into that. Obviously, feeding you back to the Lyme program has more of the pre-existing protocols with the antibiotics, especially. So always reference back to that as well. This is an update. This is kind of topping up the information bank. All right, so looking at the clinical logical flow, we're starting with, okay, what do we got for Borrelia? What's interesting and helpful there? Ivermectin, piperacillin, which we'll discuss, is not yet, but shows promise. We want to target co-infection, so that's the tafenaquine, the macrobid. We want to support mitochondrial and neurofunction, which is what the methylene blue is doing, and also playing a role with persister cells. Addressing persisters and biofilms, so dapsone, methylene blue, modulating immune response with low-dose naltrexone, support metabolic and neuroinflammatory pathways with GLP-1 agonists, and then the gene silencing strategies, which is the Q-Restrain. All right, so let's start with ivermectin. So the summary of ivermectin, it is an antiparasitic medication, but it does seem to have synergy against Borrelia, Babesia, and viruses. Ivermectin became very well known during the COVID era because people were using it to help with COVID, which is more in the virus family. So it also has some GABA modulation. It has some possible anti-inflammatory effects. Considerations would be resistance, as with most of the antimicrobials, or neurological sensitivity. And we usually pulse ivermectin and combine it with other antiparasitics. detox support, and it can be combined with other antibiotics. So when would you consider ivermectin? So patients with Lyme with evidence or suspicion of intestinal parasites would be a good indication. Symptoms suggestive of babesia, but not responding fully to like more traditional babesia protocols, which might be your Mepron, Malarone, like the atovaquone-based protocols. Unexplained GI symptoms, which again could lead back to the parasitic connection. MCAS type reactivity with no clear triggers, plateaued or relapsing progress, neuroinflammation or migratory pain, or poor tolerance to other treatments. So ivermectin is not sort of something that we'd really come out the gate and use as a first line therapy for Lyme, but it does have some benefit, and it can be interesting for people that aren't responding to traditional protocols or have done a lot of that and kind of looking for something different. So screening considerations before initiating, potentially, and this is not, this is not absolutely has to be, but one could do stool testing for parasites. I find parasites, like especially on the GI map, Doctor's Data Comprehensive Stool, Mosaic Comprehensive Stool, it's kind of hard to find parasites. So ParaWellness is a lab that I think has greater sensitivity. It's less well known, but I'm starting to use that more. So that's interesting. And then, of course, we want to assess babesia symptoms, which, classic would be night sweats, air hunger, anxiety, palpitations, and then ruling out contraindications, liver disease, pregnancy, just kind of fairly standard stuff. Dosing protocols. So this was hard to put together because there's such a spread of dosing for ivermectin. So this is kind of general guidance, but I've heard so many different protocols and dosing strategies. So as with everything, if there's an MCAS element, we just want to go slow, start low. Now, traditionally, ivermectin was dosed as 12 milligrams once, like just for simple pinworms or something like that. The commercial ivermectin comes in 3 milligram tablets. So, typical recommendations. So that's not going to do much for chronic Lyme, right? So we're going to need to do more than that. So there's various options here. Everything, one dose every 3 days, one dose daily for 2 to 3 days, then twice weekly, dosing every day for 30 to 60 days. So I would say when we're using ivermectin in this kind of context, probably about 15, 16 milligrams would be kind of an average dose for an average sized adult. The lower end would be 12, the higher end would be 20 for what I do. However, there are some doctors that go up to 35 milligrams per day, which in my mind sounds like a lot, but ivermectin is an extremely safe medication. It doesn't have a high side effect profile. And it's also used in some cancer protocols up at those kinds of high doses as well. So it's a very interesting medication. And I think there's probably a lot about it that we don't understand, but that can have good application. So for off-label use, it must be compounded. Pharmacies are unlikely to fill higher doses. They're likely to want diagnosis codes that make sense, which would be intestinal parasites. Ever since COVID, they've become highly sensitive about dispensing ivermectin. So compounded is for sure the way to go, and more cost effective as well. Okay, so let's talk about piperacillin. And as of right now, this is kind of like something that shows promise, but it's having a lot of people are talking about it and asking about it. So I wanted to make sure to include it. So piperacillin is a broad spectrum anti-pseudomonal penicillin. In clinical use, it's almost always combined with tazobactam, which is a beta-lactamase inhibitor and marketed as Zosyn. So it does exist already, is kind of the point, in combination with another drug that makes it kind of work better. Currently FDA approved for the treatment of intra-abdominal infections like appendicitis, peritonitis, skin and soft tissue infections, pneumonia, including hospital-acquired and ventilator-associated, more severe urinary tract infections, gynecological infections like postpartum endometritis, pelvic inflammatory disease, septicemia. So like big infections, big bad infections. It's mostly used in the hospital and ICU settings or home infusion nursing care for serious or polymicrobial infections. Polymicrobial means like multiple microbes. So like I said, serious, big, bad infections. And at this point, it's utilized by IV. So it's intravenous use. So what's its potential for Lyme treatment? Well, Northwestern researchers screened nearly 500 FDA-approved compounds and discovered that piperacillin effectively treated acute Lyme infection in mice at doses 100 times lower than doxycycline. It works by binding to Borrelia's peptidoglycan cell wall, effectively killing the bacterium without requiring co-administration of the beta-lactamase inhibitors, which is the tazobactam that I said it's typically combined with. So in this case, it did seem to have efficacy just by itself. Also being that it was at lower concentrations, piperacillin spared the gut microbiome, so easier on the gut than doxycycline, which needs to be dosed at much higher doses. So, I mean, this could be a game changer. And of course, we want it to be a game changer if proven safe and effective in humans. It could offer a powerful alternative to doxycycline, especially for children, because doxy is contraindicated in children, doxy intolerant individuals, or those at risk of chronic symptoms. Now, a second study by the same team also discovered that the Borrelia peptidoglycan, which is bacterial fragments, persist in animal tissues like the liver and joints long after treatment, potentially contributing to chronic symptoms. And piperacillin's targeted mechanism may help address this. So, in a nutshell, what this is saying is that even if the bacteria have been killed, there may be still bacterial fragments that can continue on in the tissues, causing more symptoms, but that may not be related to active infection. But piperacillin is better at preventing that from happening. So there's a few important things to keep in mind. Firstly, it's only in mice studies so far. We don't know if it works the same way in humans. And clinical trials are still needed before it could become a standard treatment for Lyme disease. And that's a process, right? That's a long, difficult process. Certainly things can be used off-label, but again, piperacillin right now is only given by IV. So it's not something that you can just find and take as a pill at home. I've had a bunch of patients already say, can I have piperacillin? And I'm like, no. And so it's very early days, but any kind of research study that shows promise is well deserving of exploring. So right now it would require hospital treatment or at-home IV therapy with a nurse or an infusion center. I'm sure you listeners would understand that. I'm sure you can't take yourself or send your patients to the hospital and say they have Lyme disease, that I would like IV piperacillin for them, please. Like, that's not going to happen. So still work to be done. Also, the research is focused on early infections. So we're talking about acute Lyme because, of course, there is no such thing as chronic Lyme. So, in reality, Lyme's a lot more complex. So we've got chronic symptoms, we've got co-infections, we've got immune system involvement, either immune deficiency or autoimmune. I mean, none of those factors were considered. Mold toxicity being a layer, none of those factors were considered. And just frankly, it's not yet approved for Lyme. It is FDA approved for other infections, but not for borreliosis. So using piperacillin for Lyme would be considered off-label and would require careful clinical judgment. And as with any medication, there can still be side effects, can cause stomach upset, allergic reactions, changes in blood counts. Um, the mouse study used low doses, and of course, the lower the dose that you can have efficacy, the less chance you have of side effects. So that's definitely something that it has going for it. So what's next for piperacillin? I mean, promising early stage evidence, strong targeted activity against Borrelia in mice, maybe gentler on the gut microbiome than some of the other medications. But we do need human clinical trials to determine if piperacillin works safely and effectively in people for Borrelia infection. Researchers also hope that an oral formulation might be developed to improve accessibility. That's going to make a big difference. Obviously, taking an antibiotic orally and taking it via IV is going to differ in terms of, crossing the blood-brain barrier. So I'm not saying necessarily that an oral formulation would be superior to an IV in terms of how it works, just that it would be more accessible. And then we'd also obviously need future studies and lots of experience with patients with co-infections, late stage Lyme, chronic symptoms, all of that, because this was really just a study on acute Borrelia infection. So next up is tafenaquine. So talking about tafenaquine and primaquine, because they're both part of the same drug class. And I want to just touch on the primaquine, but it's not really showing the same promise as tafenaquine. So we'll kind of move on from that. They're both part of the 8-aminoquinolone drug class, which was historically used for Plasmodium vivax and ovale malaria relapses. So it's been a malaria drug to date. Their mechanisms of oxidative stress induction, mitochondrial disruption, and possible persister cell activity are being explored in the context of Babesia species, especially Babesia duncani, which of the two big ones, the duncani and microti, duncani, I would say is considered a little bit more stubborn and a little bit harder to treat. So the primaquine key takeaways here, it's not a first-line treatment for Babesia. I have heard of doctors prescribing it. I'm not clear why they would choose that over tafenaquine unless somebody's tried tafenaquine and it just didn't do anything for them. It's got a short half-life. So the half-life is like how long does it take for half of the medication to work out of the system? The shorter the half-life, obviously, the more frequently the medication needs to be dosed to get that blood level. So the primaquine requires more consistent dosing. Can support with methylene blue to reduce oxidative complications, and cautions in patients with psych illness, anemia, or renal impairment. So the dosing is typically 30 milligrams daily. So it is a daily dosing because of that short half-life of about 6 hours. Side effects and risks, still GI upset, possible, definitely nausea, anorexia, or loss of appetite, abdominal cramps, methemoglobinemia, especially at higher doses, which we see with some of the other medications that we're going to talk about, tafenaquine, Dapsone. So that's where the methylene blue can come in to be helpful there. Hemolytic anemia, if somebody has a G6PD deficiency, also a risk with tafenaquine, also a risk with Dapsone. So that's why it's essential to get the G6PD lab testing done first to check that. Neutropenia or drops in white cell counts, corneal deposits, which are reversible, and then a little bit less common, but neuropsychiatric events. So tafenaquine is for sure the more promising agent. So FDA approval is prevention and treatment of malaria, and it's a single dose alternative to the 14-day protocol of primaquine for Plasmodium vivax. So similar mechanism for tafenaquine as primaquine, but with greater lipid solubility and a longer half-life. So the lipid solubility influences its ability to cross the blood-brain barrier, which is really kind of a lipid membrane, if you will, like a capillary membrane. And membranes are made up of lipids. So the more lipid soluble a substance is, the better it typically can cross the blood-brain barrier. The more water soluble it is and the less lipid soluble, the harder a time it has. It also has a much longer half-life, which influences the way we dose tafenaquine. So another mechanism is mitochondrial dysfunction and reactive oxygen species production within the pathogen. So this is how it's worked. Like, how does it work on Babesia? How does it screw up the Babesia? And it can target both the acute and the dormant stages, which is really helpful and useful more for the persister forms that we're kind of discovering more about. So Babesia specific insights, increasing use in resistant Babesia cases, like when Mepron or Malarone have failed, or if Mepron, Malarone have kind of, done their thing, that the patient's plateaued and we're looking for like what's next. So it can be good in resistant Babesia cases, particularly Duncani and Mycoti. Synergy with atovaquone, azithromycin, and doxycycline. So I definitely agree with that. When I start treating a patient for Babesia, I don't go straight to tafenaquine. I will still layer in atovaquone. And again, I would refer you back to the antibiotic module in the Lyme program for more of these sort of basic protocols that we've been using. But atovaquone is the active ingredient in Mepron and in Malarone. Same active ingredient. Mepron is the liquid. And Mepron works best when it has azithromycin or clarithromycin along with it. Malarone is the tablet form, and it contains proguanil, which helps it to work better. So it does not need azithro or clarithro, which are considered like part of the macrolide family of antibiotics, and can work along with doxycycline as well. I don't view doxy as much as a Babesia medication, but again, most of the times when we're treating Babesia, we're also treating Borrelia, potentially Bartonella. So some of these medications get put into the mix just to have as broad spectrum an effect as possible. So we're talking, looking at that, not so much, you wouldn't go to an infectious disease doc and be given tafenaquine for Babesia, of course. But from LLMDs, ILADS clinicians, other Lyme literate folks are reporting good impacts with tafenaquine. So typical dosing here. So the half-life is 17 days, which is vastly different to the 6 hours of the Primaquine. So it's great for weekly or bi-weekly dosing. So typically I do weekly. So what we look at is a loading dose of 200 milligrams daily for 3 days. So 600 milligrams in total, and then 200 to 300 milligrams weekly. And Dr. Marty Ross suggests 300 milligrams every 1 to 2 weeks for longer term suppression. A little bit depends on the brand as well. There's two types of tafenaquine, two brands of it. Crintafel is one, and Aracoda is the other. A lot of it for me so far has been availability in terms of which we go with. Availability has been a little bit of a struggle to date. So sometimes one is available on the market and the other one is not. And as of recently, there was even a shortage where a tafenaquine was approved to be brought in from Australia because we couldn't source it here within the United States. Adverse effects possible, as with every medication, the GI symptoms, that cornea verticulate, methemoglobinemia, hemolysis. So these are the same, pretty much the same as the Primaquine. Do not ever do tafenaquine without checking G6PD. So that's always a big caution. Psychiatric exacerbations, which I would also then question, is that a Herx reaction? Like, Babesia can cause a lot of anxiety, depression, psych symptoms. So I remember when we were using mefloquine or Lariam more back in the day, this is many years ago, and it got a bad reputation because of like psych side effects. But my question was also then, how much of that is a side effect and how much could it be a Herx reaction if tafenaquine or Lariam or any of this family of medications is crossing the blood-brain barrier more effectively, then we might be getting more die-off, more Herx reactions based in the central nervous system. Sometimes we see an increase in serum creatinine, which is reversible, and neutropenia, drop in the white blood cell count, as before. So drug interactions here, notably metformin. So there's an enhanced risk of lactic acidosis, and then just caution with other oxidizing drugs like Dapsone and sulfur antibiotics. So just watching how we're putting things together in terms of protocols. Clinical use and synergy. So often added after initial response plateaus to standard anti-babesia protocols. So that's what I was saying before. I would still typically start with Mepron, Malarone, maybe Doxy. Bactrim is a medication that I kind of use in conjunction with other protocols, but not necessarily as a standalone, but it can sometimes kick up babesia stuff too. But the tafenaquine for me at this point is not a first line med. It's like something to layer in once my patients are established on more traditional protocols. Can be introduced once inflammation is down and detox pathways are open. So, I mean, obviously, well, not obviously, it's important to support detox pathways before doing any antibiotics or antimicrobials, in my view. But the point I'm making here is just like, we get through one round of hexing, like one layer. And once that calms down, then we can be like, okay, what's the next step? And that's kind of where tafenaquine can come in. It pairs well with Methylene Blue, Dapsone, azithromycin, and cryptolepis. So it fits fairly well into those kinds of protocols. But as I said, and I'll say several times throughout this lesson, because it's so important with some of these meds to check that G6PD. All right, so combination therapy for refractory babesiosis, mitochondrial targeted treatment for persistent intracellular infections, and strategy for targeting persister cells, especially if prior Mepron or Malarone have failed. So here's some synergistic combinations, as we were saying before, atovaquone, like the Mepron with Zithro with tafenaquine, Malarone with tafenaquine, tafenaquine and Methylene Blue, and even Dapsone, Methylene Blue, and tafenaquine. So that's a pretty aggressive protocol. Protocol requires close monitoring, and we're going to be talking about both Dapsone and Methylene Blue in just a little bit here. So neurological considerations, both agents, the primaquine and tafenaquine, cross the blood-brain barrier and may induce neuropsychiatric symptoms in sensitive individuals. So that's why I was saying, okay, yes, true. And some of it could be Herx reaction, but we still want to be, careful, screen for history of bipolar, depression or anxiety, substance use disorders, just do the sort of psych screening and just be aware. Just so we can factor in all the different variables. So tafenaquine and persisters is an emerging hypothesis that mitochondrial disruptors like tafenaquine and Methylene Blue may impair energy production in persisters and biofilm embedded babesia. So could act as a persister breaker when layered with other agents. And so that can benefit patients with cyclical relapses, strong inflammatory flares. And I really am not going into any naturopathic support or protocols in this lesson, just because it's covered elsewhere. But remember also, to look at the biofilm breakers from a natural standpoint as well, because we've got some great things out there. So what about tafenaquine and biofilm? Does it really break it down? Well, not directly, but sort of indirectly. By creating oxidative stress, by targeting intracellular and dormant stages of pathogens, and by enhancing mitochondrial disruption. So, it may weaken biofilm defenses or enhance the efficacy of true biofilm busting agents, like the lumbrikinase, serrapeptades, bromelain, EDTA, NAC, Essential oils like thyme, clove, and peppermint, and Dapsone and Methylene Blue are considered to break down biofilm. So they may just destabilize the environment in which the biofilms kind of hold it together. And so they may have an indirect benefit. Monitoring recommendations, so baseline G6PD, non-negotiable. CBC with differential, we want to be checking white blood cell counts and hemoglobin. Checking methemoglobin levels is wise, I would say. Creatinine and liver enzymes, and then mood check-ins for patients with psychiatric history. Other supportive therapies that may go well, like I said, I'm not going to go into too much detail on sort of more natural supports, but antioxidants can be helpful: methylene blue, N-acetylcysteine, liposomal glutathione, vitamin C. And then, of course, GI and microbiome support, especially if combined with other antimicrobials, because the more antimicrobials you have on board, naturally, the harder it's going to be on the gut. So clinical pills, I know this is small. So G6PD testing is essential. And the reason is that both the drugs, Primaquine and Tafenaquine, can cause severe hemolysis, which is not good. Tafenaquine better than Primaquine because longer half-life, better efficacy in babesia. Oxidative risk with methylene blue reduces the risk of methemoglobinemia. So methylene blue can help balance that. Combination therapy is best, used with macrolides, which is the azithromycin, clarithromycin, tetracyclines, or atovaquone, that's your Mepron Malarone. Watch for psychiatric effects, important for Lyme patients with CNS involvement, and use with biofilm agents to increase effectiveness of persister and biofilm targeting protocols. So a summary for Tafenaquine: it's a potent and long-acting anti-babesia agent, like I said, very long half-life. It's lipophilic, which indicates that it's going to be better at crossing the blood-brain barrier, mitochondrial targeted, effective against the intracellular and persister stages. Use it in personalized protocol for resistance or relapsing cases. Screen carefully, monitor closely, as with all of our antibiotics. And supports advanced combination therapy models in chronic vector-borne illness. So I think, great role here. And it's very nice having weekly dosing. So you're not having, patients and people having to take daily, twice daily, even 3 times daily dosing. So adherence is pretty good to that kind of protocol. All right, so let's move on now to methylene blue. So methylene blue is so interesting. It was developed in the late 1800s as and used as a textile dye. And then it became the first ever synthetic drug used in medicine. So it was initially applied for malaria treatment, and then later became the gold standard for managing methemoglobinemia. And that's a condition in which red blood cells can no longer effectively carry oxygen due to oxidative stress. So over time, methylene blue has found new relevance in modern medicine for its unique properties that support mitochondrial function, cognitive performance, and antimicrobial defense, making it highly relevant for patients with chronic Lyme disease and co-infections. So chronic Lyme patients often struggle with the persistent infections from Borrelia, Bartonella, and Babesia. There is often a struggle with mitochondrial dysfunction and oxidative stress. Like that's one of the big impacts of chronic tick-borne infections, and one of the big causes for such fatigue, brain fog, things like that. We know in chronic Lyme, there's lots of neurosymptoms: brain fog, anxiety, poor memory, lack of focus, concentration, all the things, the classic Lyme brain. And then there are medication-induced oxidative side effects, like from Dapsone, that methylene blue can help to balance out. It can help to prevent and help to balance out. And we just talked about that being relevant for Tafenaquine as well. So methylene blue offers benefits on all these levels. It is used a lot in like neurodegenerative conditions like dementia, Alzheimer's, Parkinson's. And then, really good for mitochondrial support as well, and antioxidant. It's just got a wide range of how it can help. So in terms of the mitochondrial support and energy restoration, methylene blue acts as an electron shuttle, bypassing damaged areas in the mitochondrial electron transport chain. It promotes ATP production, cellular energy, and resilience under stress. And it's particularly helpful for fatigue, post-exertional malaise, neurological sluggishness, like the brain fog. And so that's great for chronic Lyme tick-borne illness patients. In terms of an antioxidant and NAD regeneration, at low doses, methylene blue acts as a powerful antioxidant. So that means it reduces oxidative stress and oxidative damage, which is a fuel for inflammation. It supports NAD plus cycling, which is essential for mitochondrial energy, cellular detox, DNA repair, and longevity. Now, at high doses, it can become pro-oxidant, but we're very, very rarely using such high doses. At the doses that we're typically using in patients with chronic Lyme, it should not become pro-oxidant. We should not be using high enough doses for that. So methylene blue can also protect against methemoglobinemia. So we've been talking about that methemoglobinemia can be a side effect of some medications used in Lyme treatment that oxidize hemoglobin, reducing its ability to carry oxygen. So methylene blue has really been the primary treatment for this condition and can serve a protective role when these medications are used. So Dapsone, especially at doses over 100 milligrams per day. So we're going to talk about the double dose Dapsone protocol. Primaquine, particularly over 30 milligrams a day. Tafenaquine, especially over 300 milligrams a day. But we've already discussed that we're not going to dose tafenaquine daily. We're going to do it weekly. And so we're not really getting to those kinds of levels. So methylene blue works by reducing methemoglobin back to functional hemoglobin, restoring proper oxygen transport, and preventing hypoxia-related symptoms. So fatigue, shortness of breath, air hunger, that can be symptoms of the methemoglobinemia. This protective effect is especially valuable in combination protocols where high-dose Dapsone is used to target Borrelia persisters. And like I said, we'll talk about that more when we get to the Dapsone section. But methylene blue can be really helpful to offset that. So methylene blue can also have antimicrobial and persister activity, especially against resistant or persistent forms of Borrelia, Bartonella, and maybe Babesia, although data is more limited. And, in terms of like what we're hearing at conferences and from different Lyme docs, we're really looking more at effects against Borrelia and Bartonella. And that I would say is consistent with what I see in my practice, of which patients are dealing mostly with which co-infections. So the mechanism, it generates intracellular oxidative stress within the pathogens themselves, disrupting their survival, even when they're in dormant forms. So particular synergy with Dapsone, azithromycin, rifampin, and doxycycline. And it can be part of multi-drug regimens targeting chronic infections that don't respond to standard antibiotic protocols. So, as I was saying before with the tafenaquine, it's nice now that we have some of these newer, not that methylene blue is new, but newly applied in the Lyme world, to give our protocols a bit of a boost if our standard protocols either weren't getting the job done or if they were helping for a while and then patients were plateauing. These kind of newer applied medications can help move the needle again. So methylene blue has a lot of cognitive and neurological benefits, and I see this in my patients a lot. It does cross the blood-brain barrier pretty easily, so it can enhance focus, memory, cognitive endurance, like ability to focus. And it supports neuroplasticity. So this was really interesting at an ILADS conference. Dr. Moorcroft was talking about this, saying that neuroplasticity, just as the basic definition, is kind of the brain's ability to rewire, grow new neurons, grow create new neural pathways. And so Dr. Moorcroft was talking about how it can also help with memory extinction, meaning unlearning trauma-based fear responses. And so I thought that was really interesting because a lot of Lyme patients do have a sort of PTSD-like pattern. And so potentially it could be helpful for that. But I certainly in my patients see benefits in terms of like cognition, memory, just clarity, brain clarity. We also see it potentially reducing air hunger, which is often can be associated with babesia, and mental fatigue, possibly by improving oxygen utilization and mitochondrial efficiency in the brain. And like I said, it's used a lot in neurodegenerative conditions like Parkinson's, dementia, Alzheimer's, and just normal cognitive decline of old age. And it can be used in lower doses for that application than the doses that we need for antimicrobial applications. So here we go again with the G6PD deficiency. That's an absolute contraindication because it can trigger hemolysis. And also with SSRIs, SNRIs. So any antidepressants that work by like recycling and preserving serotonin, that can be an interaction because methylene blue can boost serotonin production. And so I personally, in my practice, if somebody's on an SSRI or SNRI, I typically don't do methylene blue. I know there are some practitioners that if it's a low dose antidepressant and a low dose methylene blue, they'll do it. That's practitioner comfort level, but generally speaking, we avoid it in patients who are taking those antidepressants. Avoid with amphetamines. It can be stimulating. Pregnancy not recommended. So the dosing is variable. What I am finding is that in some of my patients, especially more sensitive patients, when I would start them on 25 milligrams once a day or 25 milligrams twice a day, it was overstimulating. And some people were coming back and reporting that they sort of felt like they had too much caffeine, or something like that. And so I started then backing down to like 5 milligrams. 5 milligrams once a day would be really conservative. 10 milligrams once a day, 5 milligrams twice a day, something like that. And that was still potentially helpful for like cognitive support, energy support. I do believe that if we want to really hit those persister cells of Borrelia and Bartonella, then dosing for that, we're looking at 25 to 50 milligrams twice daily. And then obviously in the double dose Dapsone protocol, which we'll cover, there are short periods of time that call for higher doses than that. But I found generally speaking, when people want just a boost in energy and brain function, the lower doses are quite good. And that can be overstimulating at higher doses. So just depends on the sensitivity level to start with. And then some people are just going to the internet or ordering methylene blue. I don't recommend that. I always think a compounded form is best for purity, to avoid additives, just consistency in dosing, quality control, et cetera, et cetera. So we do get that compounded. Fair warning, of course, it will turn urine and such blue, very blue. So that's something that I always warn my patients to expect. All right, so here's a little summary about methylene blue. So the benefit, it protects hemoglobin by reducing methemoglobinemia, which clinical relevance can offset Dapsone, Primaquine, Tafenaquine. The benefit, it can boost energy by helping the mitochondrial electron shuttle, which helps fatigue and brain fog. It's neuroprotective, enhancing memory and mental arousal, improves cognition and emotional regulation. That's another thing. I've had patients who have for sure said that their depression has improved, like the mood regulation is so much better with methylene blue as well. It kills persisters, so oxidative antimicrobial action, targets resistant Borrelia and Bartonella, and as an antioxidant, reduces ROS, boosts NAD, which aids in detox and reduces inflammation. So lots of good things there with methylene blue. So let's turn to Dapsone now. So, an overview of Dapsone. It's an old mycobacterium drug first used for leprosy. And Dr. Richard Horowitz, who is in upstate New York and one of our leading Lyme physicians in private practice, really has been the pioneer of the use of Dapsone in tick-borne disease. So, a lot of the work is coming from him, and he is published on it as well, which is great. It's nice. It's a once daily dosing. It's pretty easy on the microbiome. It's not really a standalone drug. It's always used in combination with other antibiotics. And it's effective against persister cells of Borrelia and Bartonella. It can cause strong Herxheimer reactions. So we always want to set people up for success with a lot of detox helpers, binders, etc. So in terms of the dosing, we'll talk about the double dose Dapsone protocol, but I do want to make the point that in more sensitive patients, like the double dose Dapsone protocol is not the only way we can use Dapsone. So in more sensitive patients, we can do much lower doses, like a 25 milligram Dapsone with, say, 100 milligrams of minocycline. And, in a more sensitive individual, that may still have a really good clinical benefit. So I think that sometimes with Dapsone, well, I can only speak for myself as a practitioner. Sometimes I feel like, that's the whole double dose Dapsone protocol can be overwhelming. I mean, it is a lot of medication, high doses of medication, not for the faint of heart, but that's not the only way we can use Dapsone. So we shouldn't throw the baby out with the bathwater. And there is potential to use Dapsone in lower doses. And I've spoken with other practitioners about how they're dosing it. Some are starting with like 25 milligrams every other day for a week or a couple of weeks, and then go to 25 milligrams daily. And then, if tolerated, like if they're doing okay Herx wise, working up to the 50 milligrams, up to 75, up to 100 milligrams if possible. But some will just stay at a lower dose. And like I said, still get benefit from that. So the origin of the double dose Dapsone protocol, I mean, the problem there that Dr. Horowitz is trying to address, and rightly so, is that these persister cells of Borrelia and Bartonella, and there's persisters of other pathogens too, Mycoplasma, Tularemia, Brucella, um, they're, as their name implies, they're persistent. And so we need to be constantly looking for strategies to help with that. So persisters can be round bodies, L forms, or biofilm-like aggregates, and they can revert back into active motile forms in favorable environments. So when we're dealing with these infections, we want to be working on like active pathogens and also persister forms. Biofilms play a large role for persisters, providing housing and a hiding spot. And persisters tend to be multiple drug resistant. They are dormant subpopulations of these pathogens. So some of the drugs that are effective against the persisters, Dapsone, obviously we're talking about that now, also effective against biofilm, can be anti-malarial, so potentially anti-babesia as well, anti-inflammatory, very good CNS, central nervous system penetration, can reduce autoimmunity. So, and it is a sulfone, so it's still in the sulfa drug category. Not going too much into the science of that. There are some people who are allergic to sulfa drugs who can tolerate Dapsone, and there will be a subset of people that don't tolerate it. But it is still officially in the sulfa drug category. So rifampin, also effective against persisters, especially Bartonella. Pyrazinamide, used in TB treatment. So sometimes that's also incorporated in some of these protocols. Methylene Blue, we've talked about, persistent drug for Bart and Borrelia, and reduces side effects of Dapsone. And then the macrolides, Zithro and Clarithrol, lesser extent on persisters per se, but like good in combination therapy. And I have to say, I use the macrolides a lot in my protocols to combine nicely with other things. So the double dose Dapsone protocol is an 8-week protocol. I'm just going to go through this fairly quickly. Dr. Horowitz has the information. It's published in a study. There's extensive information out there, and he's always updating and refining based on what he's finding with his patients. So he's finding a 45 to 55% effective rate in getting people into remission. He's found the 4-drug therapy more effective than 3-drug. So there's a couple of different combinations that he has worked with and looked at and studied. So original double dose Dapsone. So Dapsone week 1 would be 25 milligrams. Week 2 would be 50 milligrams. Week 3 would be 75 milligrams. Week 4 would be 100 milligrams. So that would be considered like full dose of Dapsone. And then weeks 5 to 8 goes into 100 milligrams twice daily. So that's why that's considered double dose Dapsone. So 100 milligrams daily is a single dose, 200 milligrams daily is double dose, and then 400 milligrams is quadruple dose. The Methylene Blue, and there's lots of components along with the protocol, so don't take this as like the complete protocol by any stretch. But the Methylene Blue calls for 50 milligrams twice daily in weeks 1 to 4, 100 milligrams twice daily in weeks 5 to 8. And remember, that is to try to offset the methemoglobinemia that could come with the Dapsone, especially dosed at those higher doses. So the Methylene Blue is protective against side effects of the Dapsone. So what we're seeing now in Dr. Horowitz's work is a new addition of pulses. So this could either be done as week 9 of the double dose Dapsone protocol and then every 6 to 8 weeks. Pulses can be 4 to 6 days, but people, especially with Bartonella, but and Babesia too, 6 days is kind of recommended. And that's 400 milligrams daily of Dapsone, 300 milligrams twice daily of Methylene Blue, along with doxy, rifampin, and a bunch of other things. So I've heard Dr. Horowitz present at ILADS conferences. I've talked to him personally. And his view is, yes, it's a lot of antibiotics, but what if we could do more for 8 weeks and get someone into remission as opposed to multiple antibiotics for months and months and months on end? So that's kind of the theory. And then the pulses are like, if we need a little extra to get the job done, if we need to like every 6 weeks, but still a week every 6 weeks is better than, just kind of this never-ending antibiotic path. So Dr. Horowitz also said the pulse schedule could be done even without doing the 8-week protocol, but it's unknown how many pulses would be required. My addition, just my first thought would be that's like awfully high doses to be taking without working up to them, at least with the double dose Dapsone. There is a stepping stone of 25 milligrams of Dapsone to 50 milligrams of 75. Dr. Horowitz would say that if dealing with mold as well, once done with the 9-week protocol, then start mold treatment and then just pause mold treatment during that 6-day pulse. So he's looking at hitting the tick-borne infections hard, then and then trying to clean up mold in between the pulses. So like I said, the double dose Dapsone protocol also involves many other medications. There's rifampin, there's hydroxychloroquine, there's doxycycline, nystatin. So, I'm not going to put the whole complete listing here. I just kind of wanted to focus on Dapsone as like the newer drug on the scene. And double dose Dapsone also involves a rigorous regimen of naturopathic support. Detox helpers, probiotics, antioxidants, biofilm agents, the whole kit and caboodle. So it's very comprehensive, it's very extensive. But like I said, Dr. Horowitz's viewpoint is if you can just get in there and get it done and get it over with, then that's not necessarily any harder on the body than prolonged courses of antibiotics. So caveats with Methylene Blue as it relates to Dapsone, because as I've said, the Methylene Blue is a fairly integral part of this protocol. And as in the prevention, trying to offset the methemoglobinemia. So what happens if somebody's on an antidepressant medication? And certainly we wouldn't want to do Methylene Blue at the doses required for double dose Dapsone if someone was on an SSRI, because that would be presenting a much higher risk of serotonin syndrome. So if somebody can't take Methylene Blue, there is the potential to use other antioxidants like NAC, glutathione, vitamin C, alpha lipoic acid, to try and have that benefit. But that may be so in lower dose Dapsone dosing, but you really do need methylene blue in the higher dose, the double dose Dapsone. So Dr. Horowitz will have his patients discontinue their antidepressants during the protocol. They can go back to them afterwards if they need, but that's how he plays it, because he views methylene blue as just an essential part of the protocol. So summary of cautions with Dapsone, because I know there are a few. So check G6PD first, sound like a broken record. Same with methylene blue and tafenaquine. Check CBC, CMP, hemoglobin, especially met hemoglobin levels every 2 to 4 weeks, depending on where somebody is in the protocol or with the dosing schedule. We need to give additional folate, so leucovorin, 15 to 25 milligrams, methylfolate supplement, and like I said, balance met hemoglobinemia with methylene blue and antioxidants. So watch for strong Herx reactions, can be major. Support detoxification, building the dose kind of incrementally. Allergic rash in approximately 5% of patients with a sulfa drug allergy. Like I said, most people with a sulfa drug allergy can tolerate Dapsone, but not all. So just, we need to be watchful of that. All right, so that brings us to the end of part 1 of our update lesson. So I will see you back for part 2.